I'm going to go ahead and see. A couple of things is that I think I'm trying to work on this thing about both the evaluations and the certificates that you get um, for your attendance. And of course, you claim the number of hours. There were some people that went out for 2 hours and they weren't in the sessions because they had other meetings, et cetera. So claim, what you can claim. We're going to be sending out some information. Um, that will tell you that there was, I don't know how many hours there were on day one and how many hours on day two, et cetera. And then you can pick and select from that. They actually gave us more hours than we usually have. It was, if you're there the whole time, it was 33 hours for the 4 days. So I thought that was pretty cool. And they were just gotten some of the growing pains because we had to do this at the last minute, especially on the evaluations. One of the things that we saw on the evaluation, which was really funny, was it said, was this meeting free of commercial bias, right? And then it said yes, and then it said yes or no, and then of course everybody's picking yes, and then it says if yes, why? What's the answer? There was no commercial bias, right? So anyways, we're just trying to get through some of that stuff. We alerted them to that pretty quickly and so on. Um, but what I may do is I'll put a couple of our speakers on first and go ahead and then we'll come in, maybe talk about, what you learned from it. Because I want you to be thinking about, especially if you went through and you have a copy of the brochure somewhere, as to look and see, is there something that you learned that we could pass on? Because I have to write a end of the year report to them about, what did we get out of it? Did people learn something? So it'd be good to know that I got reports from you folks, like at this meeting, which is recorded, and we can say, here's the thing I took home. This is what I'm going to change. Like a couple of years ago, Ken Shepke was sitting there already changing his protocols while we were there when we were listening to the OB, uh, that OB, postpartum, prepartum protection thing. So I got like, this is all the stuff I got to get done now, the next part, in terms of documentation of any financial disclosures that whatever, and complete participant list, overall activity evaluation summary, raw data evaluation summary. Anyways, you got the general idea. Then I've got to try to get all this stuff in. It'll be helpful, but it's actually good for me to document for them that this is a true learning experience, meaning that when you got there, this is something you didn't know or really added. Even if you were very smart about a certain topic, uh, we're talking about you learned a little bit more this time, or this little edge of it that you took home. And I'd love to, if you can think about that and put that together for me, I'd really appreciate it. And I can take some notes at this meeting as well and all that. And hey, Stein, are you on today? I don't see Stein on. Okay, got it. Because I was going to have him maybe be kind of a person who takes notes for me. Danny, Chief Oatmeyer, what time do you have to get off?
I'm just kind of still putting everything together, Doc.
Okay, got it.
So,
Well, why don't we get you on first because it's going to be brief, and then I'll move on to some of the other topics of that. And please stay on if you can. If you're getting things together and you can do it while you're listening in, I thought that'd be great. Uh, so to move things along, because we looks like we got slow participation today, but it just nonetheless, let's get going on it. So I think everyone met Chief Oatmeyer when we did the session on mass gatherings, and I work with him regularly on something called the Tortuga Festival, which is a pretty challenging thing because you're on a beach and it's a very long, lengthy kind of, with 3 or 4 different stages and people, a lot of movements and all that. And no alcohol involved, of course, being sarcastically, he said. Um, but on the other hand, we have a championship parade coming up because the Panthers, who are actually based in Sunrise, Florida, but they're the Florida Panthers, won the Stanley Cup, and they are going to have their parade down on the beach at Fort Lauderdale on A1A, the main beach drive that many of you may have been on at one time or another. And so planning for that is important. We've learned lessons just like the other day. Chief Oatmeyer was there listening to what happened at the Super Bowl 2 years ago in Kansas City when they had their parade. And there's some challenges. So I'm just curious to know what you're thinking about, Chief, just and then we'll see what happens retroactively, right? But what are the things that are you by the way, Chief Oatmeyer is a battalion chief there in the Fort Lauderdale Fire Department. He has been an outstanding teacher. His main job is to do training for everyone, but it's based on incredible experiences, things we were just talking about. So what I wanted to do was have him come on and say, "Hey, here's what I'm thinking about this week, right? And what I got to do, and and give us some of his tips, and we can ask him questions about that, or other people who've had to go through these things before. If you could add some tips into him as well, that'd be great. Okay, so take it away, Chief Altmaier.
Hey, thank you very much, Dr. Pepe, for having me on here. And basically, what I do for the City of Fort Lauderdale Fire Rescue is I oversee all the special events, coordinate resources, staffing, and everything else. So last year we had our first parade. And we had our resources, a lot of mutual aid helping us out, and it rained. It had torrential downpours, so I mean that obviously kept a lot of people out. We still had numerous calls, trip injuries, fall injuries, drinking, alcohol related medical issues. But due to the weather, I think that really kept the attendance down. This year, we're looking at a lot better weather. And I think just because it's the second one, a lot of people are going to want to come out. Guesstimations so far are 200,000 plus in attendance. And a couple of concerns that we obviously have is staffing. Do we have enough staffing? Um, and looking at where the parade is along A1A, we have obviously the beach on one side, the water on one side, and then we have north and south of A1A, and then obviously we have all the finger roads coming off of A1A. And with anything else, we're concerned about any kind of vehicle ramming incidents and protecting parade participants and the crowd with blocking off all the intersections. So we've deployed all the barricades that we have to put them on the side streets, along with different trucks, Parks and Rec fire trucks that we're using to mobilize to block access to the parade route. Um, Obviously, if there's any kind of an active shooter, our police department, I believe we've had close to 500 law enforcement personnel. We've got the National Guard here, we've got the State Guard dispersed throughout the whole event site, and we're looking at probably just over maybe a mile of parade route and where the celebration will be. So as far as staffing wise, we've got first aid tents, we've got a medical tent set up, and of course, brings us back to being in South Florida. The weather is obviously going to be a factor in that. So we've deployed some hydration stations to pass out water as people are coming into the event site. We did public safety messages regarding where light clothing, loose fitting, and also stuff to protect your feet, when walking, because parking is going to be limited on the island, and then people are going to have to walk for quite a distance. So, but again, this is the second one we had. Last year was a wash, literally, because of the rain, and we pretty much getting geared up for this one as well. So,
Chief, I was wondering, Chief, if I can interrupt. In the past, part of the problems that we've seen that we talked about last week, for example, were issues like snipers, and you have a lot of high rises, hotels along that route, etc. And how is that handled, or do are privy to that? Maybe it's something we shouldn't talk about, but that's being considered, correct?
100%. We've got, and again, with all our main events, Tortuga, all our main events, we always put police officers, snipers on the rooftops, and that also gives them vantage point to look at the other buildings to see what's happening over there. But yeah, that's always an issue when it comes to that. But PD is good about putting snipers up there.
And what time is this thing, well, first of all, what time does it start and when is it supposed to end? The event itself is scheduled, right? We'll talk about about when people show up. We'll talk about that afterwards. But what's the actual official time of the event?
The parade's going to start at 12 o'clock, and they're going to have the celebration on the stage at about 1:30 after the parade.
Okay, and then maybe that's broken up by 2 o'clock or 3 o'clock or something along those lines.
Yes, but if it's a nice day, Dr. Pepe, it's going to be, we're probably going to keep, tens of thousands of people on the beach.
Right.
Which we've got a contingency for.
Yeah. So so the 2 points I wanted to make about that in my experience, because I've been to a lot of these championship parades. I've been to a couple NBA's parades. And of course, they were in places like Houston and Dallas where the temperatures were 100 degrees and the humidity was 150%, And so very similar because you probably have, yeah, I think you have warm weather there as well, although the ocean provides some breeze. But
Yes.
the point is that people get there early to line up along the sidewalks and all that. They'll get there at 7 a.m. and they could get heated during that period of time. And so part of what I've always thought about is that we actually tell the public to actually have a buddy system in case somebody goes down, and those buddies each have to know where the closest public safety officer is or whatever it may be that they can shout to get help right away from somewhere. And then the other thing we learned from last week is that a lot of stuff happens. It ain't over till it's over. A lot of stuff happens when we think things are over and they're moving along, but that we're maybe we have to keep our guard up the most, et cetera. Those are the two things I took away from last week, et cetera. Anything you would add to that before I go to Mike Feldman? Danny, anything you would add to that, what I just said, about, people coming early, first of all, and then,
So we're actually looking at setting up, and I just got off the phone with Parks and Rec to set up our hydration stations. And I told them, 6:30, we'll set up the tents, and then our crew will get out there at around 8 o'clock and start delivering the water. So again, at that early, we'll have them along the beach as well. So even if we don't catch them coming in off of ELO, we'll have hydration stations along A1A that they'll be able to get water from. But yeah, our concern is, and again, parade starts at 12. 200,000 people are not showing up right at 12 o'clock. So they're gonna,
right.
and this goes back to the old air show days when we used to do the air shows in the 90s and the early 2000s. I remember reporting to work at 600 hours, and there was just hundreds of people just coming over the bridge, ready to stake their claim on the beach to get ready for the air show. So this is going to be the same. This is going to be the exact same thing. People are going to be coming early, setting up, and then just waiting for the parade to start. And then that's where all the complications are going to happen.
So Mike Feldman, out of Toronto, you have a question or a statement to make?
Yeah, no, I'm just curious. We have a Caribbean Waterfront Festival every year. And during the parade, there's very limited ability to move patients. And so we have fire boats, marine paramedic units, police boats. When I think about your trap between the beach and the intercoastal, do you have a lot of boat capacity for transport if you need to during the parade?
We do have fireboats, and it's, we're set up in between the beach and the intercoastal, so we do have access to water. And the good thing is one of our fire stations is probably, maybe a quarter mile south of the event. And if anything, we could run a patient down there to put him in the fireboat to take, but we're also not too far from the hospital. So we do have, if we do get anything in the water, we always just take them to the 15th Street Fisheries, and we could pick them up from there. But as far as we do have access to getting patients on the water, and if there was a mass evacuation, we've got all our water taxis that will be available to get people off the island.
Okay. Any other questions or statements or experiences that anybody's had with these? And if not, then I really appreciate you having on. And so anyway, it sounds like the wedding's off, right? At least you're off.
Yeah. And funny thing is, last year I was supposed to go to a wedding. My wife's Greek, and she's got a big Greek family, and all set to go to a wedding. And the Panthers won the championship, so I had to cancel that one out. And a year later, another Greek wedding, and I have to end up canceling out and working this. But I'll hopefully I'll get up there afterwards. But hey, thank you very much, Dr. Pepe, for having me on.
Yeah, and then congratulations on another Greek big fat Greek wedding, right? And
Yeah.
and then congratulations, more importantly, to the Panthers in this case. It's really exciting because they've gone to the finals 3 years in a row and they won the last two. So it's kind of funny when you think about Florida and Tampa Bay, being these dominant teams. It doesn't seem to make sense, especially probably to people like Mike up in Toronto. All right, and then
not Tampa Bay, Paul, not Tampa Bay. Don't confuse the Panthers and the Bolts. I've got friends in Tampa Bay who would get very upset about that.
Yeah. Okay. Well, I'm just saying that 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 you have these great teams that are down there.
Down
In Florida.
down in Florida. Yeah, it's
Yeah,
kind of strange.
that's what I was getting at.
Yeah.
Um, so, all right, I should get Rob Dunn on pretty quickly. But anyways, for your information, Danny, then I'm gonna head up. I'm gonna get a flight today about 3 o'clock. I should be in by about 6 p.m., 7 o'clock tonight. Let me know if there's anything I should know about or where you're gonna be tomorrow. I'll be glad to hook up with you and learn a little bit more about what you're doing. Okay?
Yeah, we'll be moving assets tomorrow, resources. So just give me a call, Dr. Pepe, and we'll connect.
Hey, thanks again. You're welcome to stay on. The next thing we're gonna talk about is China and the MS system there, and and what Rob's takeaway was. And so Rob Dunn from Detroit. And by the way, Chief, thanks again for being with us last week as well. Everybody enjoyed having you there, and it was really good to have your perspective as well. So thank you.
Well, I appreciate it, Doc, and I'm going to have to get back to this logistics stuff. So, but
Okay.
thank you very much, and we'll connect tomorrow.
All right, see you later. Okay, Rob,
All
go
right,
ahead.
bye-bye.
Okay, so tell us about the Middle Kingdom and what you learned and what you thought about it.
Yeah, so just briefly, the Global Network on Emergency Medicine is something our university, Wayne State University, has been involved in for a long time. We have a pretty active global health program. We run a global health research collaborative with virtual mentoring across the world, statistical support for universities and collaboration with a lot of different systems. So our team has been involved in a number of these meetings. I had not gone to one of these specific ones before, but this year the Global Network on Emergency Medicine was looking for someone to talk about some of our EMS programs. So my chair, who some of you know, Brian O'Neill, suggested that I should go to this, and it was a really interesting experience. It was in Guangzhou, China, and it was let's see if it'll actually move. There we go. They had a very sophisticated center that they were hosting this at, and their academic medical center that was here in Guangzhou is very progressive, does a lot of EM, but specifically a lot of EM research. And a couple of my takeaways, number one, as you would expect from a country that has a bit more of a command economy and some top-down organization, they had a very well-organized medical research system. Of course, the other takeaway was that some of the experiences that the researchers were having are exactly the same as those of us who do a lot of research have all the time. Many of the presentations were talking about, how they've been trying to work with their leaders to get more funding for their particular research. And, when you talk to the individual researchers, it was the very similar experience, I think, that any of us have trying to get our projects funded and trying to get enough to expand them in a meaningful way. The other thing I took home is that the EMS and emergency medicine providers are basically, even though different society, different governmental structure, different culture, are really living in the same world that we are day to day, right? They're taking care of patients on the street. They're taking care of patients in the emergency department. They had a massive agenda of stuff. They had simultaneous translation of everything. There were people from all over the world presenting. There was kind of an international track and a number of local tracks, and it was a fascinating conference, as good as any conference that I go to. I did spend half a day at the large hospital, the large academic center, where the med school is hosted, that had some just amazing stuff. First, they had a simulation center that was 3,000 square meters, so it was quite a large simulation center. Their ambulances were based out of the hospital. Their dispatch is based at the hospital as well. Serves an area of about 20 million people, and has a tiered deployment system that they have been also piloting some mobile ECMO ECPR in, and they were presenting kind of their next step with their mobile ECMO program at this, to cover the entire region with mobile ECMO units and with ECMO center destinations for post-ECMO care, and presented a consensus document for their region that hopefully they hope to replicate in some other areas. Beijing has a fairly active ECPR program as well, and there was a lot of interesting back and forth with the international folks depending on what was going on in their cities. This is one of the ECMO simulator trainers that they had. The technology piece there was just amazing. Really blew my mind, the amount of medical technology that was available. Here we basically have kind of, two brands of monitor defibrillators plus another brand sometimes. Their vendors, there were at least 10 different vendors offering monitor defibrillators, many of them smaller and lighter than what's in the US. There were multiple very compact ECMO machines and pretty sophisticated equipment. This is one of the ambulances that's designed for their mobile ECMO team. And as you can see kind of in the back, I think I might have another picture of it. Yeah, they've got this kind of double tiered stretcher, power load type of stretcher that has the patient on top, room for all the equipment that you would need from ECMO underneath to make sure that the whole thing is completely mobile, and you're not having to schlep a bunch of stuff. And that was pretty impressive as well. They're very well covered with wireless technology, as you'd probably expect for communications, cell phone location data. This is one of the mobile ECMO machines that they had in the vendor area, but this is the one that they were using in their ambulances in Guangzhou. And when we visited the emergency department, they're using some predictive early warning systems on all monitored patients. Interestingly enough, they're kind of living in the world that we are. They stay very focused on wall times for handoff. They have, a 12-bed area that had 20 patients in it. They had a fair amount of patient boarding. They had patients sitting in the waiting room with their suitcases, and very much, other than everybody speaking a very different language, the emergency department looked exactly like almost any emergency department that you've been in. They see just over 100,000 visits. They're a tertiary care center. And the docs were kind of, working in the same ways that any of our docs were, but using a bit more sophisticated technology. They had multiple different ultrasound machines, and provided this kind of, like I said, this monitor that you see here. There's predictive early warning that people you're seeing like the red have had some changes in their vital signs. So people who have some changes that are significant, drops in blood pressure, changes in respiratory rate, will automatically pop to the top of their monitor board. There's a separate one that just looks at every patient, so that the physicians have the early warning vitals in front of them. So some predictive modeling. They had some predictive triage modeling as well. But overall, it was a fascinating experience, both looking at the differences and what's universal in providing emergency care. Very sophisticated EMS and EMS communication system, but again, with some of the same challenges that we have. I kind of feel like that was like what I did on my summer vacation thing at the beginning of the school year, but it was very interesting trip, and a good collaborative support for what our university has been doing. Of course, many of our postdocs who are from China now are we don't know if we're going to get them back, but that's a whole different story to talk about.
So, hey, Rob, you have to get going. This thing.
Yeah, I can talk for a minute if people have any questions or anything.
Okay,
but
good. I just want to make sure I was being sensitive.
But I love the technology.
Okay, interesting enough. Do you have a sense of what it's like if you were living there and you had to get a response for an injury, let alone a cardiac arrest, etc.? What's the sense? Are there trauma centers?
Yeah, trauma centers, cardiac centers, stroke centers, very advanced stroke care. They have a 911 system that's similar to ours with some of the same challenges. Guangzhou uses medical priority dispatch, actually, just like many of us do. And according to Jerry Overton, they have a pretty good presence across China. And they're doing the same QA, and have some of the problems that things get missed by the dispatcher. It takes a while for CPR to get the cardiac arrest to get recognized and give the CPR pre-arrival instruction. And they're working on some of the same things with telephone CPR improvements that I think most of us have been working at. And the same thing with their pre-hospital care. They're in the Paros registry, which is very much like CARE. Some of you have seen like Marcus Ong from Singapore present some of the Paros data. So it's a system that in many ways, when you get down to the nitty gritty, forget about the politics and the government and everything else. When you get down to the nitty gritty, it's facing the same, kind of QA and outcome interests and concerns that we all face.
Yeah. You're what I consider one of our relative experts on stroke care. And so you said they had a pretty good stroke system. Does it include, what does that include? Is it they have a good stroke scale and identification? Do they have comprehensive centers? Do they suck out clots?
Yes, so they have comprehensive centers. They have, something that looks like a thrombectomy capable center, and they have primary stroke centers. They do time-based destinations. They use a version of what looks like the VAN to do some pre-hospital decision making.
Yeah. Okay. Well, so that's great. Does anybody have any questions or comments, or anybody else had similar experiences over there? So it's a little bit, having gone to several countries in Asia recently, it sounds like they're a lot more sophisticated than some of the other, let's say, neighboring countries, and in the region as well. So that sounds pretty cool. Then that sounds good. So it sounds like you had a good time. How's the food? Was it good?
Yeah, it was great. The food was great. So that's, Guangzhou is, what used to be called Canton, and a lot
Right.
of what people think of as Chinese food, Cantonese food. But yeah,
Yes.
it was food. It was a lot of food, right? They have a very tradition of feeding visitors, so they keep bringing out stuff. You got to pace yourself, and drinking the bijou liquor that is
Oh,
probably
yeah.
better for like cleaning grease off of car parts than drinking. But everybody walks up to each other, and you got to drink these things. Now, fortunately, it's clear, so you could dilute it a little bit, and then they
Did
didn't
they have one of
necessarily
those?
know.
Is almost every time when you dine, did they have one of those things that circled around?
Oh, absolutely, a lazy Susan, a gigantic lazy Susan. Yeah.
Great. Okay. Roger has a question or a comment.
Oh,
Which one?
You're on mute, bud.
hi. I must have butt dialed a hand raise. I don't know how that happened. Sorry about that.
All right. Well, no problem. Yeah,
That's great.
I'll jump back on the meeting as soon as I just my fellow decided that we had to meet at noon about his research project somehow. So.
Great. That's right. Okay, good. All right. Well, listen, hopefully you will get back on. We have a great comment. I think you're going to hear from Amal next. Okay. So, all right. Anybody else have any other questions or anything to do or any time restraints? Otherwise, I'll move on to Amal then. Thanks, Robert. That was a good report. I loved it. And then I'll see you at ASAP as well. He's going to be coming to the ASAP meeting that we're going to go. And Amal, I don't know if you're going to be there, but we're going to run a pre-conference this year at ASAP. So it's going to be on that Saturday. If you can make it a little early on, they don't have funding per se for people for it, but if you're already coming, you're welcome to join us. Let me know if you want to come for that Saturday. Okay. So
Sure. I don't remember what day I'm going, but I'll be there at some point. So we'll stay in touch.
Yep. Okay. I'll try to get you plugged in. All right. So let's move on. So Amal is interesting because we just had a report about CBD not too long ago, like about last at our last meeting actually that we have at 10 o'clock with the Florida folks. And I think this is going to be an interesting follow-up to that. So if you don't mind, go ahead and tell us how the evolving data has come to more of a hits, or even as we say here. So why don't you go ahead and take it?
Sure. I'm sure you're going to get good at town on the puns here. So just as a representation, I'll start with this case. And this is just one of a handful of cases that we have, and people have emailed me a handful of their cases as well. So
Sorry about that. Apologize.
I'm sorry, what's that? So this is
I had a bunch of barking dogs, and I apologize.
oh 32-year-old guy, a young guy with no traditional cardiac risk factors comes in, and I'll just kind of jump right to the chase. He's having a big anterior wall myocardial infarction, and without any risk factors. He's young, he's otherwise healthy, but the one thing that he and multiple other people in this case series that we put together have in common is just frequent use of marijuana. So we first started becoming aware of, and he ended up having a 95% left main. He had a good outcome. I've got one or two cases of cardiac arrest actually that happened before they could get to the cath lab. And we first started seeing information on this marijuana. At least I first started seeing this maybe about 10 years ago. There was some smattering of articles that started being published, and the majority of thought was that this was probably related to smoking the marijuana. And so maybe there's something about the smoking itself, and maybe not so much about the marijuana. This was one of the earlier articles that I had come across, and the early articles were really just focused on marijuana. But I'm just going to flash a bunch of articles up here, all from the past 1 year. And this is a really, really hot topic in the journals, the emergency cardiology articles that I've been following. And it's expanded beyond just marijuana, but also other cannabis products, including medical or medicinal uses of cannabis, and also not just smoking of marijuana, but also edibles. And I'll show you the most recent article on that topic in just a second, that cannabis products, especially ones with higher levels of THC, or primarily ones with higher levels of THC, are associated with accelerated atherosclerosis, not only in the heart, but there's articles coming out that are demonstrating young people with acute ischemic stroke and also venous thromboembolism, DVT, and PE. These are a couple of very recent articles, and another one that I'll show you in just a second. So just to summarize what the cardiovascular effects of cannabis are that have been identified in these articles, a lot of it has to do with the very similar type of things that we think of with other cardiac risk factors: stroke, MI, increased incidence of CHF, and the rise in systolic blood pressure. You kind of think that marijuana is kind of a downer, and it chills you out a little bit, but it actually activates the sympathetic nervous system, so it can be associated with a rise in heart rate and systolic blood pressure as well. Atrial arrhythmias, ventricular arrhythmias. This is from one of the cardiology articles published talking about medical cannabis, not just the recreational smoking of marijuana, and a number of different cardiovascular effects that have been identified. What most of these articles really seem to agree on is that there's an increased risk of MI and stroke, increased heart rate, elevation in blood pressure, maybe as much as a 5 times the risk of MI in the first hour after smoking marijuana. That almost sounds like cocaine, some of the articles that we had seen on cocaine about 20 years ago, and a 3-fold increase in risk of mortality in patients who already have underlying cardiac disease. This is the most recent article that I saw. This was published just last month. And in this article, what they found was that marijuana smoking and also the edibles are associated with endothelial dysfunction, leading to accelerated atherosclerosis. And this was written in the lay press, indicating that people that regularly are using marijuana had risks that were comparable to tobacco smokers. And so there's been an increasing push that I've been seeing that this should be incorporated, that possibly should be incorporated as a risk factor for premature atherosclerosis, like many of the traditional risk factors that we use in the heart score. And we're starting in our protocols at University of Maryland, in our hospital system, we're starting to consider marijuana as one of these risk factors as well. Over the years, we've learned about other risk factors beyond Framingham. We know that chronic cocaine use accelerates atherogenesis, lupus and other inflammatory disorders, chronic kidney disease, HIV, chronic alcoholism. We've added all of these as primary risk factors for premature atherosclerosis. And based on what's coming out in the literature, there is really I think there's a growing push that maybe chronic cannabis use, whether in the smoking form or edible form, should possibly be considered a risk factor for accelerated atherosclerosis as well. And this is really not common knowledge at all. I gave this talk up in Canada just this past April, and you figure, well, the Canadians must know about this because they legalized Canada many, many years ago. And people, the vast majority of people really had no knowledge at all about the cardiovascular effects, as well as the cerebrovascular and the venous thromboembolic effects of chronic cannabis use. So this is something that I think we need to get word out about to our patients and also providers, that that for patients that are using cannabis on a regular basis, even without any other of the traditional risk factors, I think those patients really do need to be considered at increased risk, and it's probably worth spending some time counseling our patients about this as well. And I'll leave it at that
Okay.
for comments.
So let me ask a couple of questions. So I think it's very important to delineate the issue about whether it happens with edibles versus the smoking part, the actual inhalation into the lungs, et cetera. I mean, what I learned day one when I was in medical school was that if you were smoking a pack of cigarettes a day and you went down, and you cut it out, that your risk factor went down 2.5-fold, and it was all related to platelet function. Is it have something to do with the smoke and platelet function, or is it the drug itself, or do you have any insights into that?
Well, what I would say is that based on the literature that I'm seeing, the early literature thought it was just a smoke, but the more recent is suggesting that it's not just a smoke, but the drug itself.
Yeah. And so I wonder if it has some vasoactive properties, that makes your blood pressure go up and heart rate go up and all those kinds of things, right?
Yeah, I don't know if you stepped away when I was mentioning that last article on endothelial dysfunction,
Yes.
but that's been shown to be true for both the smoking and also the edibles as well. So
What I wanted to understand about the endothelial dysfunction, what does that mean, that the muscles will increase their tension, or the vasovasorum are changed, or what happens there? What's the actual let's say mechanism that might raise your blood pressure?
Well, it's not the blood pressure, but I think it increases platelet activation.
Okay.
Yeah.
Okay, so it is maybe a direct drug effect, and that's important to delineate, because you could even take orals that way, and it becomes an issue then. That's interesting. Okay, anybody else have any questions or challenges, or anything else to say to that, or an experience with this, or anybody heard about this before?
I just have there's a question in Q&A from Dr. Wayne talking about, is this also true of CBD only without the THC? And that relates to the last webinar guest we just had in Florida.
Sure. Based on what I've read, the higher the concentration of THC, the more risk there is.
Right.
So all of these hemp products, and hemp is usually defined as having a very, very low concentration of THC. The hemp products are at much, much, much lower risk. I don't know that anyone can say zero, but I haven't seen saying that, the hemp that's added to your coffee or whatever is going to be putting you at risk. But it really seems to be related to the concentration of THC.
Yeah, so our last presenter started a company around 0 THC, and he's had it tested, and now he's done studies on it. But to get it to 0, so the line firefighter won't fail a drug test. Interesting stuff. Yeah.
Interesting. Yeah.
All right, and so anyways, well, thanks a lot for hashing out some of and there's a joint policy then, to repeat that again, ACEP is putting out a policy here with who, with respect to who?
ACEP is putting out a clinical policy to talk about this accelerated atherosclerosis. I don't know when it's coming out, and I don't recall if it's a joint policy with a different organization or not. I don't recall that. I know they had put this out for comment among the clinical policies committee, but I'm guessing in the next several months that will be published.
Okay, got it. All right, anybody else have any questions or answers here?
That was funny. A joint policy. I thought you were making a pun, but you weren't. Okay, never mind.
I'm guessing Paul was, but that's just going right over my head.
I'm always, like I said, here we are hashing out all these things. Okay, and I think it's And you hear there's a grassroots efforts to define whether it's THC or CBD, et cetera, Peter. So that might be it. So and then this is no token. Right, I could go on and on.
Let's get over the hemp.
No.
we
Paul,
gotta-
you are smoking today, that's for sure.
Well, yeah, it's scary, and the worst part is I think I've really damaged Peter because I start hearing him make. He actually had some really good puns at our meeting last week. I have to give him credit. It was really pretty good. So anyway, so I not that, but I look at I blame this all on Len Hudson, right? You guys all know that it all was his fault. That he was the one that got me started on that. All right, so well, I think that's basically it from that point of view. Thanks a lot for being here. And then
Thanks.
tell your bride that she needs a trip to Fort Lauderdale or to even Key West after a meeting that you want to go to in Fort Lauderdale next year. So our meeting is actually going to be in Fort Lauderdale, right near the beach. Actually, right off of A1A. That's funny, where we were talking about today earlier with
Yeah, that sounds great.
the
Yeah.
chief. And it's gonna be June 1st is when we usually arrive. That's for the meeting because the Eagle Creek starts at 8 o'clock in the morning on June 2nd and 3rd. And then the 4th and 5th will be that Thursday, Friday when we have the main meeting. I'd love to have you be part of that. Okay. So, all right.
Sounds great.
Hey, Bill Baumer, have you heard anything about this? Since California has been such a pro, weed state, so to speak. Any comments, or are you familiar with any of this data here that we were talking about, and you have an opinion?
Can you hear me?
Yes, sir.
Okay. Yeah, we always had a risk factor of combustion products of cannabis and marijuana, and we would always ask for that. But we typically did not go in detail or prevention for the edibles. So this is interesting. What Amal showed is that the edible may be a pharmacologic effect. If it affects endothelial function, that would allow more LDL particles to migrate into the vessel various times, could accelerate atheroma, plaque, and obviously relatively young plaque is more likely to rupture or erode. And when you do that, it exposes it to the platelets stick, aggregate, and you get thrombus, and then you could get strokes and heart attacks. So I think this is interesting. Obviously, this drug has been around for 50 years or more, and we're just getting into looking at some of this related to edible, which is actually new for most clinicians.
Okay. Thanks. So okay here. So here it is. This is a good place to get started and think about it anyway. So as it is. Before we go further, I'm trying to think a couple things. I'm trying to see what else I had on the thing. Got that. Okay, good. I think we got most of our stuff taken care of here. I always try to increase everybody's. By the way, I try to increase everybody's. What's the word? Vocabulary a little bit, as you could probably see here with some of the things I put on the agenda there, such as pathogenic and panophaic, etc. So I hope you can learn what that is. I think maybe I'll have a new what do you call it, vocabulary thing every week for y'all. Hey, so before I go any further, Don, are you on? Have you finished your ICU rounds today? Because I know they can be busy some days. Don Jenkins. I don't know if you switched over or not. Hey, Dr. Jenkins, can you hear me, or by any chance? I wanted to ask you a quick question. Nope. Okay, that's it. Yeah, well, once you get on, if Dr. Jenkins, if you can hear me, once you get on, let me know or raise your hand and I'll come chase you down. Okay, if you don't mind, I wanted to ask you a question. So, all right. And it sounds like Mick can't join us, probably doing a shift or something important somewhere. I was trying to get him to sign in and see what's happening over in his realm at this point in time. And Mick, it was a great contribution last week, especially with your experiences with Crowd Crush and all that kind of thing. And that was fantastic. Thanks a lot. And congratulations on your award, by the way, which is long overdue and well-deserved, etc. All right, here we go. Peter, yes.
Yeah, I just wanted to mention the mixed presentation was very excellent. And yesterday on Netflix, there's a new documentary about Astroworld, but
Yeah,
there's a rapper in Houston.
yes,
And I couldn't stop but think about the presentation that Mick was making, and I think 9 or 10 people died.
yeah,
Lawsuits of $750 million. So
yeah.
crazy
And
stuff.
Oh,
actually,
can you hear me now?
yes, I can, Don. I'll come to you in a second. I was,
in my office back there.
anyways, I was going to say is that I was actually asked to be the medical expert on that thing to say how the medical people performed, and it was all, the security organization was just absurd. And, I have, I'm close I am to a lot of a lot of the security people for these large events. And they were explaining to me that this would never have happened because they quickly can intervene and see what's happening. And they'll actually go to the stage and tell the person to stop, etc. But this was they just carried on. It was like part of the shtick, and it was bizarre. Mick, go ahead.
Yeah, I'd seen some of the commentary, Peter, on the Astro World, and it was interesting. They were talking about giving naloxone early to some of the people in the front of the crowd, but when and they start breathing afterwards, so they presumed there was a drug element. But if you have all these people with their chests crushed, and then you suddenly take the pressure away, they will all start to breathe over a period of time if you're giving them resuscitation, CPR.
Yeah.
But it's an interesting phenomenon, these crowd crushes, and how they happen and how quickly it can happen at those very, very large, high density events.
Well, it's funny because you actually saw a cop in the movie, in the documentary, and I was watching with Allison last night. I'm like, oh my God, this guy's giving this guy Narcan. What are they thinking?
Yeah.
And the first, I guess, 30 minutes or so, people thought that people were being injected with opioids in their neck, and to not understand that you only had room for 35,000 people. You sold 50,000 tickets, and another 10,000 came in without tickets because they were jumping the fences. I mean, it's quite obvious, and they knew apparently beforehand that it was going to happen. So it's really bad.
It was just awful. But in any event, yeah. So yeah, we actually might be, if you don't mind, Mick, if you maybe in next week or two think of something, maybe do another presentation and follow up a little bit for us. We'd really appreciate that. I think it's another good, because I'm dealing with that today again. I mean, tomorrow or Sunday, whenever it is. Again, once again, and it's a common thing. But I've been fortunate to work with the best security people in the business and organizers, and unfortunately, it didn't happen in this particular thing, and actually knew the people that were involved. I'm going to move on to I'm going to move on, just talk about feedback from the meeting, and maybe even go through the agenda a little bit, and because I think most of what we learned was at Eagle Creek itself, which was really great because we even go through the agenda at that point in time. But I want to also be able to take some notes on, and maybe even Peter, maybe we'll have this, what's the word? This is recorded, so maybe I won't have to worry about that. But if someone can take some notes for me, I would really appreciate what we hear here. And for example, I think, and then, hey, Johnette, are you on with us today as well? Gilding? I don't know if you're there or not.
Yes, I'm here.
Yeah, so you took some notes at our meeting, right, about what you do, because one of our docs had asked to have a toolkit if the hospitals are closing down. We want to know, is there a toolkit or things we should be thinking about if you're faced with such a problem going forward? So you took some notes, right, for us? Is that correct?
Well, I took some notes, and I also have, I don't know if this would be helpful for everyone, but I created a timeline of the event from the day we got the first text that it was closing till, actually it's still going right now. I'm still adding things to it. So I have that timeline, and if it would be helpful to anyone, I'd be welcome, or be able to share that.
I think what we might do is, a lot of times in the past, we've done things like this, toolkits or some guidelines for suggested actions to take from the Eagles in the past. We've had it for example, for wall time. We've had a paper we put out on that, and we've had some others. So this might be a nice little thing to put together. Maybe we can write it up, etc. If you want to help us, or even be a primary on it, that would be really cool, because it would help other people as well, etc. And then, how'd your meeting go yesterday with the Chiefs? Okay, anything learned out of that one?
Yes, it went very well, and I'm so excited that we're moving forward and looking at another level of transportation and care. so that we're not sending advanced life support staff and equipment to
Yeah.
basic life support needs. And so we're looking at putting that in place for Brevard.
Yeah.
I'm very excited about that.
That was, and what's his name? Dr. Purse's talk on Friday morning. I wish you had seen that, but we can probably get a copy of it or send to you. Peter, you might have even, did you do a video, Peter, of some of the meeting?
He just took a call. Oh.
Oh, I did. Okay. Got it. Okay. Well, okay. Well, but anyways, that's what I'm getting at here. Same thing here. I want to see if there's some things we can get going forward under these circumstances, learning from this whole meeting, et cetera. Sounds like you learned a lot as well, didn't you?
I absolutely did, especially not being a clinician. You guys
Yeah.
taught me a lot.
Okay, good. And I was really pleased that you were there the whole day. So thank you so much. And thanks for what you're doing in Brevard as well. All right. So let's move on. Don Jenkins, two things. One is thank you for the report you sent me today, but we're not ready for prime time yet. So you don't want to discuss that today. But you and I
do.
Oh, you do want to talk about it today?
Yeah.
Oh, okay, fine. I didn't know if it was something we were supposed to keep close to the vest because this is what do you call it, recorded and may go out to the world. That's all. So you want to go ahead and record it here? Okay.
Yeah, I dumbed down the details to
Okay, got it. Okay.
keep it.
And then before you start there, tell me about the Plasma Verde, Salsa Verde.
Yeah. So green plasma. Brian Cotton from Houston, trauma surgeon friend of mine, stumbled upon this in the ICU one day when the nurses were sent a bag of plasma, and he noticed that the bag of plasma was green in color. I was like, "What is that? That doesn't seem good." And searched and identified that in fact green plasma is not an uncommon phenomenon. It comes from female donors primarily taking oral contraceptives. The higher estrogen intake apparently changes metabolism in the liver to cause more ceruloplasmin production, which carries the copper, which gives it then that green color.
Oh, so it's not like a Billy breakdown or something like that, right?
Oh.
Okay.
Yeah.
Ceruloplasmin. Okay, that's great.
And so it is exceptionally potent in terms of clotting function enhancement, much more so than regular old-fashioned yellow plasma. So I'm working with South Texas Blood and Tissue here in San Antonio to petition our regional obstetric colleagues and Planned Parenthood to make a push for plasma donation for those women taking contraceptives to see if we can't enhance that plasma production line with more potent plasma. So the jury is out working. We just communicated with Julia Coleman from Ohio State and Shabani Patti from San Francisco about studying the effect of the increased ceruloplasmin plasma on the glycocalyx of the endothelium to see if that's part of the reason it seems to be more effective. So we've got a phone conference set up for next week for that.
That's interesting. And, I'm going to tell you, there was some work that was done some years ago by the folks, I think, God, where was he from originally? But anyways, looking at estrogen, for example, in resuscitation, including in different areas in different places. And I wonder if that's part of the effect as well as the estrogen there. So that's interesting. Okay, so this is going to go into a whole new world. So again, one of those bumper sticker things, Eagles, you heard it here first. So that's fascinating stuff. So I want to learn more about that. So I may even remember I have to give a talk for you at the. By the way, here's the announcement again. On July 14th and particularly on the 15th, there's some things going on the 14th, but on July 15th, we will have the National Whole Blood Summit in San Antonio at the Gonzalez Convention Center. And it will be it'll be a fantastic meeting run by our friend here, Don Jenkins, who apparently I hear you're like an award-winning surgeon or something. Is that true?
Well, you would know.
Congratulations and well deserved, because you've made things public health so much better. You had a great contribution there. So glad you got the Anderson Award. It really was
Very,
good.
very, very appreciative of that.
Yeah. So, any event, so that sounds good. Since I have to give that presentation on plasma, and I was going to introduce the whole thing. You heard my presentation at Eagles, where I just talk about, the disparities, but one thing we can do to protect the glycocalyx is the TXA and the in plasma. So this might be something else I will mention at that time. Is that okay with you? And maybe,
Absolutely.
and you'll get me smarter about this. Should we use it, for example, in head injury as well? Because that's my primary talk that I'm going to give. But let's
So that is my reason for this push.
Okay, got it.
That's
Okay.
exactly the reason.
All right, so let's, maybe I have to drive to the airport this afternoon, but either this weekend or, on the way to the airport or on the weekend, let's talk about maybe where I can sit down and take notes. That would be fantastic. I want to learn a little bit more about this and, be somewhat smart. You can make me look smart. Okay. So, all righty. Thanks a lot. This is good. Hey, so listen, anything new about calcium? Here I go. Right.
Yeah.
So it
I
just
don't,
happens to be right.
I can't find the screen share.
Oh, let me see if I can do the share here. Maybe I'm in charge. Multiple panelists can share simultaneously. Maybe you can do it now.
Let me look under more. Huh. I am not. Oh, wait.
May have come up now because I'm sharing now. Okay.
Found it.
Hey, Mick, just want you to know, Mick Malloy, just want you to know you're typing away and it sort of shows up on the screen. So you may want to change your angle there. So yeah, thank you. Because it gets distracting. That's all.
So are you able to see my screen?
No, 275 whole, but yeah, I could see it. Go ahead and put the, what do you call it, mode? The, presentation mode. There you go. Perfecto.
How's that?
Let's put this in perspective. Was this a study you did? And was it a controlled trial? Was it a, half the people get it, or is it just a random study? Or what? Tell us a little bit more about how the design of the study.
Yep. So straight up observational. We went back and looked at a 3-year block of time at the injured patients receiving emergency release whole blood. And there were about 550 patients. By the time we whittled out the people that were like DOA or died in the trauma bay, and identified those with the available parameters, that got whittled down to 275 whole blood recipients. Historically, this was a 40% mortality group in our center, and you can see that in our first year of experience, that mortality went down to 25%, and you can see it now is sitting at 13%. So there's something about whole blood resuscitation right up front. But what we were doing was based upon the concerns raised. Does calcium help? Is it should empiric calcium supplementation be given when transfusion is being given? As we heard at the conference last week, it seems that this is helpful in the New Orleans resuscitation program, where they give TXA, red cells, and calcium as a part of that bundle of care. We just decided to come back and take a look at this. And what I can tell you is that this is what we found, is that there is an improvement in mortality when the supplementation is with calcium chloride at 1 or more grams per 2 units, for each 2 units of whole blood.
May I interrupt you for a second? What your screen is kind of blocked by something. Is everybody else seeing the same thing where it says give subtitles a try?
Yes.
Yeah, it kind of seems like it's it's blocking your screen somewhere. I can't.
Maybe you could just click on it and delete it.
Okay.
Yeah, so I don't see it.
Interesting.
On my screen.
Let's see if I. I'm clicking on it. It doesn't.
Oh
do
wait.
it.
It's yeah.
There you go.
It.
Got
Right
it.
there we go.
Got it.
All right.
All right,
Got
let's go back to, so let me just repeat. So far, you said you got the 275 people who, after excluding all the pulseless people, et cetera, and the people who died in the emergency department. And then you sort of just on a grossly saw raw data that the mortality was lowest with calcium supplementation greater than 1 gram per 2 units. So the question I have for you is that, well, let's go on. Then you said when you did the multivariate analysis, it was independently, associated with a 62% early mortality. The reason why I was asking this before you go on here is that the issue is, just, is there something else, another factor in there why you chose to get more calcium, in other cases versus the other, or is that, is it just happen to be you're again observing what you have and then and analyzing it?
Yep, this was straight up observing the practice of our clinicians.
Okay. And
So I'll tell you that there were a bevy of patients, like up to 20%, who got no calcium.
Okay. And do we know what the reason was there? And is that just some clinician decide not to give calcium, and then we're looking at
or didn't think of it, or
yes,
great questions. Only about half of the patients had ionized calcium levels measured.
okay.
So
So when it says here, so you're saying the calcium chloride is what happened. You're saying the gluconate formulation didn't have that same effect, but that could be confounded by the lower ISS. Is that you're saying?
that is correct. It looks like that those patient populations are not comparable.
Interesting then. Okay. And then we have to sort out, was there a reason why they got gluconate and reason why, whatever that was different.
Yeah, so as it would turn out, it's almost a 50-50 chloride versus gluconate administration.
Interesting.
As it turns out, our pharmacy's default is to grab the gluconate and let that run in over an hour. So not only do you have, right, so the chloride is bioavailability is 3 times greater than the gluconate, and you're going to administer that in a sort of a medium time IV push over 5 minutes or so, versus the 1 hour infusion of the gluconate. So the immediate bioavailability of that maybe that's why there's a difference. It would appear, but we don't want to hang our hat on that because the groups appear to be different.
Yeah, that's important then. But at least it's hypothesis generating that we need to be looking at that. I've had people tell me that even when they've had folks who, let's say had liver transplants or something like that, it was still working okay. Is that the only slide you're going to show, by the way?
Yes.
Okay, great. So it is, but it may take time when you have someone who's in shock anyways to get to the liver and get whatever, broken off. Well, okay, that's fantastic then. And I think this is really great new stuff for us all. Do you want to get out of the share, by the way, so we can see you directly?
Yeah, I'm not sure if I know how to do that.
Okay. There's a thing that says stop share. You aim towards the top, and then it says stop share, I think, somewhere up there. I don't know if we can stop it for you.
I wish it did. Let me see here.
Well, I got an idea. Maybe I can block it.
You can shut me off.
Yeah, maybe. I don't know if I can or not. That's the only thing. Let me see if I'm going to share myself right now, then I'll show you how to do it. Okay, here we go. So I'm going to, there we go. You're out of it now, I think, or I'm talking. There we go. That's what I did. I took it out. All right. So I think this is fantastic. Now, I had the impression that you didn't want this to go out anywhere. Did you change your mind, or how are you feeling about this, or what?
Yeah, no, because I didn't really provide any details. I provided the answer that, that this seems to be, there is a positive effect of calcium administration in patients getting transfusion. And that was a question that was raised at the Eagles conference based upon some data out of Alabama. And I think that this may refute that data. So I brought it forward to say, if you have a calcium utilization protocol that you've been using.
Yes.
I wouldn't abandon it based upon what we know today. And here's more data, not a randomized controlled trial, but a pretty good observational trial set. And we did not intend to show a benefit, right? We
Yeah.
did this. We were as skeptical as everybody
Yeah.
that this was a thing, but that's how it pans out.
And I knew you said that. So it's really fascinating then. Okay, that's good. I'm just glad you have the data. Let me ask Dave Miramontes if you don't wouldn't pipe up, because these are your patients as well that were taken in. Do you have any perspectives, or you feel like you agree with what conclusions that were drawn here?
But so we still don't know that if giving it in the hospital and giving it in the field is going to cause a benefit as opposed to giving it in the hospital.
Okay.
We still don't know that question. And I mean, logistics is just another thing. I know the New Orleans folks are using it as a bundle, which is great. But do we have time? Like with our short ETAs, I mean, the whole bag of blood isn't even given by the time they get to the trauma bay.
Yeah.
So I'm not sure this answers the question. It points us in a direction, but we need to know is giving it sooner better, and does it make a difference?
So that begs the
It
question.
doesn't appear unsafe.
Yeah.
Yes.
That was the question, sort of the thing that was raised, like this might be unsafe.
Yeah, because there are effects. So Don, just so then maybe I should make this clear, is that so we're saying these are situations which calcium was given in the emergency department first. Is that what I'm getting from this? Is that correct?
That is correct.
Okay. So this is emergency department. So it does, as David says, doesn't answer pre-hospital, but I'm always, a person who says the earlier the intervention, the better the results. And so maybe it is somewhat protective and better at this point, at this point in time to think about it. I think there's always, again, every action has a reaction. Like if you put calcium into somebody, is that going to lower potassium? Is it going to suck up phosphate, things like that? But if you're having calcium removed and then that causes an imbalance that way, then you probably do need to replace it. And I always have my general therapeutic intuition has been that if something happens slowly, you replace it slowly. If something happens quickly, like here, okay, then you got to replace it quickly. So I think this goes along with where my biases are going. So that's interesting then. All right, well, thanks. This is great to have those data. So thank you so much for presenting it here. Is this the first time you've presented it anywhere?
Yeah.
There you go. Eagles heard it first here. So that's great. Thank you so much for that. So I'll be calling you. What's your day like tomorrow? Do you have anything going on?
I got the ICU again tomorrow.
Oh yeah, of course. You're demanding patience. I can't believe them getting in the way of this. Okay. No, but I could call you in the afternoon or something like that, right? So no.
Yeah.
Yeah. Okay. Good. All right. We're so glad you joined us at the meeting last week, and just glad you were honored because you deserve it. So I just so pleased that you were there and be able to hang with us as well. So, and especially at the dinners that we went to. So that was really good. So thank you so much. Okay, so let's see. I guess we can go around the room. I want to ask a few questions of various people. So I'm trying to think if there was anything else I wanted to say. Oh, talking about the meeting itself, I could go through the agenda here a little bit. If I can maybe I can pull it up real quick and see if it just remind people about what was in the main meeting. Okay, so let me see if I can find. Okay, go to folders. Go to first there. Hard Rock. Okay, here we go. We go to topics, I think. Where is topics? And Peter, you and Stein took care of the our presentations going on a website. Is that correct?
Well, I think Stein's going to be doing that.
Okay.
But yeah, but we do have all the PowerPoints, and hoping to get up soon because a lot of people are asking for them. So that's always a good sign.
I don't know how this happened here. Let me see how I pulled up the wrong thing there, I guess. Let me try this again. Go to recent folders. Let's see, first care. Submitted topics. Maybe that's not what I want. I got to figure out where I thought it would be in there. CME, general non-responders, topic, general comments. Oh, here is survey, non-responders. That's just me getting the topics. Okay. Oh, brochure right here. If it was a rattlesnake would have bitten me, final brochure. I'm just going to use this as kind of a prompter for everybody is look at what we did here. So again, next year it'll be the week before in terms of block your calendars now, get requests in, get your fellows signed up, et cetera, et cetera. Okay. So so the first thing was the issue of I don't know, did anybody learn anything new from this section? Particularly, I think a lot of it was old hat for us because we've been through this. We knew there was new policies, and that might be a good thing that we're all familiar with the policies. And then the definition of defining what's an OB desert and what we should do about it, or some of the things we heard about precipitous deliveries, et cetera. Was that new for any of you, or did you change practices because of that? Would be really important to know. And I thought I learned a little bit here myself about, going to a birthing center because I haven't had direct experiences with that. And to see that both sides are going to complain about each other, that's a cerebral vascular accident waiting to happen, right? So in other words, it would be a thing that we have to anticipate and know how to deal with that, and maybe train our folks to be more diplomatic or whatever as they go into it, even if they're going into a real storm, so to speak. SH storm. So and then I think that was kind of a fun interaction with Dr. Ramos. I'm just glad that she was she's really gotten to be appreciative of what we're doing. Anything else anybody would say about that particular section about maternal health care that they learned from, or anything you would add to it that you would take away?
The only thing I would say, Paul, is that several people commented that they were happy that this topic was brought back. I get the sense that there are a lot of people, including my own agencies, who are on the fence. And I think Don mentioned this the other day, but as far as the Eagles putting together some sort of CPG on this and other topics, because you really can't find this information really truly anywhere in one document that's been vetted by others, and it's probably out there in our individual protocols, but I think that would be a good next step, in my opinion.
Okay, so what's that next step? I'm not quite clear on what you're saying.
A clinical practice guideline that's vetted by our group.
Okay, and you're saying for OB care, right? Okay.
Yeah. Yeah.
And then does that include also then going into the issue about birthing centers and also precipitous deliveries and all that kind of thing, right?
Well, I think most people have a precipitous delivery, aspect of their protocol. I know that's not something new. I would focus on the new stuff, if you will, the antihypertensives, treating preeclampsia, eclampsia.
Okay.
Looking at blood pressures, all that.
That's fine. And maybe that's something I can assign to Ben's, Ben Weston to maybe lead us on. I don't know if Ben's on right now. I don't have that list in front of me right now. Roger, you have a comment?
Yes, I thought she was a fantastic speaker, but one of the issues in looking at what we could do immediately, and it's an area is, how do we communicate with the masses of a large EMS system, which we all are. We have what's a 5-minute drill and a sticking points program. And one of the things I thought about a 1-slide 5-minute drill, she had mentioned how important it is to potentially clue the ED in on the applicability to some of these patients, on being able to make sure that they got to their postpartum 6-week appointment on time. And so the 5-minute drill I had in mind was to educate both our ALS and BLS providers to ask that historical question about recent pregnancy for the 0 to 6, the postpartum 0 to 6 weeks, and then ask them specifically, hey, have you had or are you scheduled for your postpartum appointment? And the minute they say, well, I missed it, relay that to the ED, because remember, these moderately high blood pressures in the average person who isn't pregnant anymore doesn't even register on our radar. But in this particular, it could be a lifesaver. That's something she pointed out.
Okay, just making sure that we have, so part of our protocol would be to alert the emergency department and choose the right place to go to, number one, and then alert them. One other thing that I would go along was that I thought was a cool idea to think about anyways, is like a community paramedic program that takes care of these. It links in with OBGYN people in the area, et cetera. I thought that was a cool thing as well. David, you had your hand up? David Miramontes?
Yes, I did. So a couple things. There is a NEMSB ACOG video. It's 45 minutes. It's available on, I think it's on the Prodigy Network, that goes over the whole preeclampsia, eclampsia thing in detail. There is a consensus document for just Google NEMSB ACOG, it'll pop right up. And it has all the things on hemorrhage, on the preeclampsia and the eclampsia. But we need to make that more EMS friendly, like Peter was saying. Because, like, for example, on the bleeding one, they talk about misoprostol. Yeah, that's a no-go in Texas, right? That drug is of the devil, according to the redneck folks in the legislature. So anyway, so we could probably make that more user-friendly, but that document's already available.
Would that work then in a liberal state like Florida, right? Yeah. Sarcastic, right? So, right. Hey, okay, fantastic. David, I don't know if you want to take the lead on that, or you're a busy guy or whatever, but that would be
I would get a fellow or someone to work on that.
All right, good. Sounds
That's
good.
a good project for a fellow.
Okay, great. Thanks, Peter, for the suggestion. I want to move on real quickly because we only have a few minutes left here, and I want to sort of bring out everybody's thinking process if they write evaluations. One thing I learned from the blood area, I thought was the thing Dr. Roach brought up, was that you could have a normal, shock index. Shock index is a great tool, but you got to interpret it as well. And in those cases, he had people with normal shock indices, but he went back and he looked at there were people that were entrapped in some of these situations, and that is an interesting association. But also, they also looked sick or they had altered mental status, and that's what prompted the paramedics to give the blood. And in every case, it was appropriate, even though the shock index was something. So that was one thing I learned. In other words, understand the relative values. I think a lot of people probably learned about plasma for the first time and how it works for TBI. So I thought that was a good thing that we all got from that. Anybody else have any suggestions about what they learned from it, from that particular session or so on?
I would also say if you can't do whole blood or you can't do red cells because of logistics, think about doing thawed plasma.
Yeah, TXA and plasma. Yep. Okay. That guy who gave that talk was kind of a weak speaker, but I think that was good. The next thing was
hey, Paul.
Yes.
It's Jim. I just got aboard. The shock index in the elder population is just not a useful instrument.
Yeah. So I think we just have to. I think the shock index is a general thing, but remembering that it could be a crashing patient, it could be a person on the toprolol, or just they can't, whatever. So I think that we'll have to revisit that a little bit. And then Don, maybe that's something you and I can work on or talk about, down the line when we get together tomorrow. Okay. So, and then I don't know if there was Eric. Go ahead, Eric Bank.
Hey, sorry, I don't have video, but I think as a whole, I think end-tidal CO2 gets ignored as an indicator for blood, and I think we brought that up during the meeting, but I think that needs to be highlighted.
All right, good. So that's something we should talk about as well. As that was something we learned from, and not only that, but I learned. I mean, I think it's really cool for people to say, "Oh, yeah, we could probably use plasma for sepsis and for." Because there was actually really good studies on sepsis. Sometimes when we do tank them up, maybe we are washing out glycocalyx and you get leaky capillary syndromes and ARDS and whatever else. So maybe plasma is a better device to be using under those circumstances. So I think bringing that up for both burns and other conditions and sepsis was appropriate. And I think we need to, I need to learn more if there's studies out there on that. But I think just the point that we brought it up, that we said, oh yeah, we better start thinking about plasma for that. And maybe green plasma as well, right, John, as we go through this. So thank you, Eric. That was good. And your presentation. Yes,
remember, it's septic shock. We're trying to deal with the endothelium. I think we need to make sure words matter. Septic shock.
Yes. Okay, good. Yeah. Yeah, you could define it, which again might be end-tidal CO2 and things like that. Okay, which is really cool. All right, Peter, you're going to say.
Paul, yeah, just to let you know, the phone call I just took, we're we're just putting the final touches on our burn protocol for plasma.
Okay.
And we're working with Dr. Holcomb. We're not going with sepsis just yet, and the reason is we see about 1,300 septic shock cases a year, and it's just it's hard to spend that kind of money right off the bat because it's a lot more than burns. So it'll be burns next is what we're going with.
Okay, good. And then the other thing is, excuse me, I think the other thing I learned was there's a whole bunch of stuff, I won't repeat it all, from the mass gathering thing, and then, and from Meg's thing about the attacks, and, and then what we heard from Dave in BC. It ain't over till it's over was a good theme. We all learned that, I think. Then when hospitals close, I think we may get that list from that we were going to get from Jeanette, so that would be really cool. I was glad she participated in that. Anybody learned anything about the issues that for example, Glenn was dealing with in New York, or what Kevin was doing, or Ben, etc., to find other homes for people? I think I think some of us know that, but it would be a good thing I think the audience would probably learn a lot from all that stuff that we saw. And then Dave Persis thing he gave the next morning, etc. Anything anybody learned about? I'm going to skip ahead. The one thing I learned about was this wheelchair thing was really interesting. I thought when we get down to when dependency depends on us. And the other thing I learned was the new stuff that is getting put into. There's my vocabulary test, excipient, right? Which is usually an inert substance, but the xylazine to metamidine. What's the new fentanyl additive du jour that we have to be looking for, and how does it change things? And then, things about how you can educate your community, the take back programs. These are all, I think, interesting things that we did learn from under those circumstances. I thought that the naloxone thing that John Jude did was pretty interesting. I may have been bringing back here to have further discussion with us on that. I thought that was pretty cool. Anyways, if you guys have I'm going to wrap this meeting up anyways, but I just wanted to, have you all think about this, things like, learning about how to avoid CPR pre-arrest cases, or getting organs saved, etc. So go through your thing and see, hey, that was new. I think there was probably, I could list easily 8 things that I didn't know about, or at least I learned about from you guys when you were putting these talks together, etc. So do me a favor, take a look at this and see if there are things that you can say that you could add to your evaluation. So I think that was a good start.
Yeah. So
go ahead.
So things that we've already changed. So 2 of our agencies are already doing DSCD after shock number 1. I had a conversation this morning already about amnio IV, and I love John's lecture about getting it in the first 8 minutes. And so those are, and then the whole Narcan thing for cardiac arrest is something that we've decided not to change the protocol, but we're going to float it to our EMS captains during like a verbal meeting, and then start to evaluate it over time. And then with the plan ultimately to protocolize it.
I just thought it was interesting that there is a pharmacological explanation for that. And I think that may end up being kind of a cool thing that we could do, all that. But should it be a long-term controlled trial by somebody somewhere? We have enough cardiac arrest where we could do it. The problem is, like everything else in cardiac arrest studies, unless it's witness ventricular fibrillation in those short times, there's so many confounding variables that I think I find clinical trials to be almost impossible in cardiac arrest cases nowadays, etc. Even though I was Mr. Controlled Trial early on, but nonetheless, I think it's just something we should explore at that point in time. Okay, that's good, Peter. Thank you for bringing that up. I think I want to sort of go ahead and wrap this up, but I just wanted to say hi to a couple of folks that are on and so on. Joe, thank you for your contributions, by the way, Joe Holly, and I appreciate you being there and going on. And Libby Char, thanks again as usual for you being on. We really missed you this year, so hopefully you can make it on next year, etc. Okay. And Mick, of course, thank you for being there. So real quickly, Ted Lee, tell us what you're doing nowadays. Can you do that? I saw you joined us, and I know that I tried to send an email to you at Clarion. Of course, it didn't work. So you're no longer working for Clarion, right? Ted Lee? I don't know if you're hearing me or not.
Yes, sir. Yeah, thank you. Clarion has been going through some restructuring, and my contract was canceled as the editor in chief. So they'll be moving in a different direction. So I'm kind of on the look, as they would say. I've been able to secure some part-time stuff, but looking for opportunities. So that's the joy of the business sometimes.
Fantastic. Okay, good. Well, I just wanted to, yeah, just it's great to say hi to you and all that, find out what happened. Going back to the OB thing that Dave's going to maybe pawn off on a fellow, maybe you can do that collaboratively with Ben Weston as well. Does that sound okay, Ben, to you? Okay. Hopefully it's okay for Ben as well. So Ben Weston, if you're there, just I don't know if you heard me or not. Anyways, David, just make sure you get Ben in the loop because since he was one of the first people to bring this up for us, I really would appreciate that.
Yeah.
And then I see that we have Dr. Ray Fowler on. Ray Fowler, is that your name? Is that right? So I understand you were the first Eagle, right? You were the very first one, right? So how's that?
You asked me one time why I kept going by the comparative when I was so superlative. Fowler. Okay.
Yeah, that's right. I get it. Sorry about that. Okay. Yeah. So how
great reports back from the meeting. Brian Miller was just so excited about the group. So thank you for wonderful.
Yeah. We thought he was fantastic, and he came up with really three or usually I try to limit people to one topic or two topics, but he had three different topics that were so good that we couldn't resist upping. And he had 4 or 5 other suggestions, but the ones he did were very good and well received, etc. He did a good job. He worked with us, and he, so he's got eagle-like mentality. Let me put it that way, in approach. So he's a very welcome member of the group. He did a good job with us here. So thank you. I'm glad to hear that he had a good time. Okay.
Oh yes, very, very upbeat.
So where are you today? What planet are you in right now?
I am a triage kind of guy. We're I'm sitting here in the tele room and reading the cardiograms and looking at folks as they pass through.
Yeah. So in other words, you're in the Parkland Emergency Department where it's like a base station that goes out to other people. Is that correct?
Right.
All right, cool. Hey, and then I just talked to my bride and she said, what is Ray Fowler up to? We got to get together with him. So I'll be back here in town on Monday. And so maybe we can get together sometime next week. Let me know.
Yeah. And I have a bottle of champagne.
Yeah.
Which we must check the cork carefully.
I think that's important. Okay, fantastic. Okay, Ray. Hey, Crawford, you were fantastic. I just love your talk on the wheelchairs. I think it's more applicable, not just the drug people, but to a lot of us old timers are going to need wheelchairs within the next 10 years. That kind of thing. So I think
yourself.
Yeah, I think it should be something that we should all be thinking about. That was a great talk. So thanks a lot at the meeting. Did anything that was a take home, since yours was one of my take homes, anything else that you took home from the meeting that you could think?
I always come home feeling inadequate, so I have a lot of take homes. But when I get back to Philadelphia, I feel depressed.
Yeah. Oh God. No, I don't think so. I think because you're so funny because you always are kind of ahead of us on many things, and you're so matter of fact about it. So I think that's it. And Terry, I thought that I heard really good compliments about you yesterday. I was talking to somebody, John Jew specifically, who couldn't. She's on shift today, so he couldn't make it. So I couldn't have him publicly humiliate you. But I just wanted to let you know that he was saying really nice things about you and Art Kellerman too. Who Art couldn't be on this week, but he'll be on next week, and they're going to give us an update on CARES. I think maybe with Brian McNally as well. So just to know that'd be kind of a cool thing. Okay. All right. Well, I thought this was a nice little meeting. There's a lot of stuff we covered. So thank you all very much. And then again, for those who keep track of your CME, today's code was 21388, 21388. And Don Jenkins, thank you for the green plasma and calcium talks. That was, on the spot, just sort of very spontaneous. Really appreciate
Paul?
it. Yes.
They mentioned looking for fellows for one of the topics a little while ago. We have 2 brand new, especially the maternal topic. I think we'd love to take a look at that.
Okay, got it. So we'll have Dave take the lead on it, and along with Ben, and then have you make sure that now Dave knows that you want to plug in with it with your fellows as well. Okay.
Right.
All right. Sounds like a good thing. And maybe we can make it some compendium that comes out from Eagles, as a, not a position statement. I want to make sure that's clear. It's just an informational statement, right? Like we're talking about the toolkit for when hospitals close, that kind of thing. I like to always emphasize that we're not some special group. We're just people that are helping each other out. Okay. All right. Any other final comments from anybody? And then Mick, if you could think about maybe doing another little presentation for us on one of these shows, that would be really good for me, to drill down a little bit more, maybe even use the example that Peter was talking about as a nice, as a nice suggestion, is that thing. All righty. So with that, I'm going to close off. I'm going to head myself out to the airport, and head down to Fort Lauderdale. And thank you all for joining us today. And then hopefully I'll be able to get a hold of you tomorrow, Don. Thank you very much. That was a great presentation, especially on a short notice like that. And I love getting that from you at 10 o'clock at night. Hey, we have data.
And happy longest day of the year.
Oh yeah, did you see did you see on my presentation that said no postpartum dissension? That was like instead of a depression, it was just we were such agreement on everything. And I said my greatest takeaways from Eagle Creek, moderated by Dr. Summer Solstice, right? So, by the way, Summer Solstice was supposed to be with us today, but she can't make it till 9:42 p.m. Central Time tonight. Okay, just let you know. So, anyways, that's our best to Dr. Solstice, and this is like almost everybody says it's the longest day of the year. There's probably one longer day than that, which is one of our Eagle Creek meetings, right? That's a pretty long day. So go ahead, Nick Malloy. Go ahead. Yes, sir.
So for us, this is a historic festival day as well. So this is the festival of St. John the Baptist's birthday.
Oh, yeah. Okay.
And so we would have had bonfires all around the country commemorating this day going back 1800 years.
Oh, okay. And so that will continue. Will people still do the bonfires?
But it actually happens on the 23rd, not the 21st.
Oh, okay. Got it. That's interesting then. Okay, so that would be Monday. Okay, got it.
Yeah.
All right. Well, thanks for announcing that to us. Yeah, we all need to know that. So anyways, it's hot here, and it's going to probably get hotter. So, all right, Ray, I'm so glad to see you. Makes me happy. Okay, I'll see you later then. Take care, everybody. Thanks a lot. Bye-bye. Oh, welcome back, my friends, to the show that never ends. I forgot. Okay, we'll see you next week. Take care.